and welcome to today's episode of A Cancer Conversation with the Georgia Cancer Center at the Medical College of Georgia at Augusta University. My name is Chris Curry, and I am the Communications and Marketing Manager here at the Cancer Center. Today's episode, we're going to be talking about a unique clinic that was built as a partnership between a number of care providers at Augusta University Health, including the Georgia Cancer Center. And these two gentlemen are going to help share all the information about it. They are Dr. Daniel Miller and Dr. Gary Ravel. Dr. Miller is the Chief of Thoracic Surgery and also the Director of the Cancer Center's Lung Cancer Screening Program. And Dr. Ravel is a thoracic medical oncologist. Thank you both for being here today.
Thank you, Chris.
So before we dive into all there is to know about the Thoracic-Oncology NOW Oncology Workgroup clinic that y'all are a part of starting, let's learn a little bit more about the two of you. Dr. Miller, what led you to a career in surgical oncology working with lung cancer patients?
Well, I grew up in Kentucky, and at that time, Kentucky was the #1 tobacco producing state, just a little bit ahead of North Carolina.
Okay.
And I went to medical school at University of Kentucky. So I saw a lot of patients with lung cancer, and unfortunately, a lot of those had late stage disease. And so that got my interest into that. And then when I selected my residency programs at Georgetown University for general surgery, and then the Mayo Clinic in Rochester, Minnesota for cardiothoracic surgery, my focus was on thoracic oncology and lung cancer. Whereas a lot of my partners in residency were going into cardiac surgery,
okay,
just taken off and so forth. So
yeah,
I wanted to focus on something that I felt, would help my friends, colleagues, families, in the state of Kentucky.
Why was that important to you?
Well, it's just because as you know, with lung cancer, it's the #1 cancer killer in the U.S. for both men and women since 1986. And unfortunately, when they usually present with late-stage disease because the lung doesn't have the best nerve endings in it. Essentially, you do in your central airways, but when you start having symptoms, 3/4 of the time, it's already gone regionally to lymph nodes or other organs where they're unresectable. And that's the highest chance that someone can be cured from lung cancer is to undergo surgery. And now with, other therapies with that, you can improve their survival. So my main goal was to help those people to have a fighting chance. And so that's why I wanted to change that attitude about smokers and so forth.
Yeah. All right. Dr. Ravel, why did you choose this career path?
So I've been fascinated by cancer and the underlying science. And obviously there is the human component to help patients with this dreadful disease. The way it manifests, like Dr. Miller was mentioning, most of the times it's metastatic. And it was very fulfilling to kind of help these patients through it, kind of walk them through the treatment, be there with them to every step of the way while they're undergoing treatments. But equally challenging and kind of, hardening was the fact that there are newer advances that happen on a daily basis almost. Mm-hmm. And the science of it is progressing so fast. And so for me, it was very kind of challenging and hardening at the same time that I could, use those skill sets in staying abreast with newer technologies and newer treatment options in furthering the life expectancy of lung cancer patients.
Could you talk a little bit about maybe one or two of the biggest advances that you've seen during your career?
So the biggest advance was immunotherapy that we saw. And then like I tell my patients that all of us make cancer cells in our body, all healthy people, but the immune system is able to get rid of them. So for lung cancer patients to have developed this kind of cancer, the cancer is hiding from their own immune system. And so Dr. Allison received the Nobel for the discovery of these markers that then have been turned into a drug, which we now routinely give patients in our clinic. And that has been a significant advancement in treatment, beyond which there are multiple other newer treatments that are available now for cancer patients, for lung cancer patients.
So let's talk about the decision to create the Thoracic-Oncology NOW Oncology Workgroup clinic. Why did you and your team feel like this was the right decision for lung cancer patients?
Well, the big thing when you're talking about who's going to treat that patient, there's a lot of physicians that are involved. Thoracic surgeon through a surgical candidate, and pulmonologist helps us to diagnose and stage the patient. And then depending on their stage and what treatment, medical oncology and radiation oncology all comes into that treatment plan. The problem was if you'd see, the patients would have to see each individual doctors, 4 different ones, and that could take 2 or 3 months to get the program going. And when you have cancer, you want to be seen now, you want to be treated now. And so that's why we came together starting in October of 2022. And so we have a multidisciplinary clinic on Wednesdays, and it's all 4 physicians are there. Thoracic surgery, myself, interventional pulmonary medicine to help stage and diagnose, and then medical and radiation oncology. So what we're trying to do is decrease the time to treat. Because if you look at a lot of places, it can be anywhere from 60, 70, 80 days sometimes. And we're trying to get that under 2 weeks. And by working together, we can do that. And so we've got great nurse navigators within the clinic to help to make sure that all the material's ready for us to see. There's nothing worse than someone having to come and having to get another test or so on. But they've been a great job of doing that. We've seen a little bit over 50 patients now. Okay. And the patients love it. I mean, when you can see 4 physicians at one time, and for us all talking about them, and we make a consensus on what it is. It's not like the big bad surgeon always has the hammer to say what goes. We talk about what's going on, and now there's a lot more studies that are going on that pre-treatment helps and improve survival. And Dr. Ravel can talk a little bit about the checkmate trial and so forth would be great.
Absolutely. So I'm really glad. This was a huge need that under the leadership of Dr. Miller was able to be kind of materialized. So I mean, I cannot overstate the impact it has had on our patients. So yes, I mean, it was something that the patients really cherished, because now, like Dr. Miller was mentioning, you're cutting back on the treatment times. You're cutting back on having to wait in waiting rooms for 4 different physicians or doctors to see them. Cutting back on the to and fro travel that patients have had to wait. And more importantly, you're having kind of this group of doctors other than a doctor who are kind of talking about the patient's care and case. And there is a degree of reassurance that gives the patient that there are 4 physicians who are all engrossed in caring for that one patient at a given time. And so it has been hugely successful to that end. And I feel like that's it is a standard of care now, in the sense that now that we established that this is something that should be a benchmark in trying to improve patient care moving forward.
And the other thing I think is very important is getting a family member to be there with the patient. Because a lot of times if they have to go to 4 visits and they have to take off, a daughter or son have to take off work, that's tough. Because when you're talking to a patient about the care plan, you're going to tell them one thing and they miss that that's 2 things. I mean, we all do that. So if you have a caregiver with you, and a lot of times, standing room only sometime in those examination rooms, but I think that really helps with the family just to all be on the same page. And if the patient wants to record the visit, we allow them to do that, because they go back and they listen and so forth. And so that's why when we talk about a patient, we're all on the same page in what our plan is.
It sounds like, so all 4 of y'all go into the room together?
Not necessarily.
Okay.
It just depends on if it's stage 1 disease, I'll be the only one in there.
Okay.
Or if the patient on the PET scan, there's a nodule, interventional pulmonary will see him about this is a bronchoscopy. We have to do robotic to make the diagnosis. Okay. But then when we have patients that have advanced disease, we'll all be in there.
Okay. And that sounds like it can be a little intimidating to see 3 to 4 physicians walk into your room at one time. How do y'all sort of approach it to be like, no, it's not overwhelming. It's actually better for you because we're all here in the room at one time?
I think the big thing is you're not talking down to the patient. You're talking like we are now at their islet. The thing too, I love to show every CT scan, every PET of what we're concerned about. Because when you tell somebody, I've got a 13 millimeter nodule in my lung, we think that's a lung cancer. What does that mean to them? So you show the scan, you show the PET scan. I always talk in food. I love food. So like I said, well, this is a blueberry or this is a green grape, but your lung is 3 loaves of bread put together. So it's not really that big, but they take pictures of the scan and so forth. And so it really puts them, because we're all visual learners, and it allows them to look at things and so I think that goes a long way.
And I think the other thing that the patients also value is that it's like Dr. Miller was mentioning earlier, it decreases the time to treatment. Because once they see us in the NOW clinic, next stop is treatment of some sort. It's either, medication or surgery or intervention like, a bronchoscopy or something. But you're getting to the actual treatment for it. And I think when somebody is distraught with cancer, that means a lot to them. That, you're shortening that time. As opposed to, now you're going to see that doctor, now you're going to see that doctor, now you're going to see that doctor, and then we'll get there. It's like getting to the meat of it,
And sometimes it's been so long, we have to repeat some of the tests. Like another MRI of the brain or so. And so it's just not a cost effective. So if you can do this all together, it's not only a financial thing for the patient, but also the confidence in us. That's what we want to build, because they're going to be with you for a long time. At least 5 years, cancers are considered cured at 5 years. So we're going to be seeing them a long time. So we've got to start off on the good foot from the beginning.
And you already see them even longer than 5 years, right? I mean, there are potential follow-ups down the road.
Well, and that's why a lot of times we see a lot of patients now from our other cancer types, like for breast cancer, head and neck, and so forth. They're cured of those cancers and on their routine screening surveillance. We'll see a nodule in their lung, and there can be either, a lot of times it's a new primary lung cancer, and so forth. So we all work together. We started this in thoracic oncology because I felt we had a tighter net group of people. And so now the cancer center is going to look at in the future going for the GI malignancies, breast, urologic, and hepatobiliary, and so forth. So we're working all the kinks out and so forth, and it's actually working out very well.
That's awesome. Let's talk about the risk factors for developing lung cancer. We know smoking is a leading cause, but there are other ways that we increase our risk for lung cancer, right?
Yes, there is. And if you look in the United States, there's about 250,000 people who develop lung cancer every year in the United States. And unfortunately, if you look at the overall survival, only about 22 or 23% of those people will beat their disease. And so there is high risk factors. And the number one is smoking, but also to asbestos exposure, radon, certain chemicals, benzenes, and so forth. But also, too, in the United States, 40,000 Americans a year can develop a lung cancer when they've never smoked. And that can be from second-hand smoke exposure, either from parents or spouse or at the workplace and so forth. A lot of times when people have a history of malignancy, especially with head and neck or breast, why do those people get that cancer? And then, especially for breast cancer, they'll beat their cancer 5%, and then they'll pick up a lung cancer, and they had never smoked. So the big thing is just educating. The U.S. has done a great job in the amount of adults that have stopped smoking. Right after the Korean War, that was the highest. About 46% adults in the U.S. smoked. Now it's about 16 to 17% in the state of Georgia. So we've done a great job with that, but there's about 100 million current or former smokers that we still have to look after and to screen. Luckily, there was a large national study that was carried out called the NLST.
NLST.
Yeah, it's a national lung screening trial that was in 2002 through 2004. It enrolled 53,000 patients in the U.S. It was done by CMS and the NIH at 33 sites throughout the United States. And it randomized people between a CT scan annually for 3 years versus a chest x-ray. And patients had to be between the age of 55 and 77, had to have smoked at least 30 pack years. And to calculate that, that's 1 pack a day for 30 years or 2 packs a day for 15 years. So it had to be more than 30 years. And they had to be a current smoker or within 15 years. What that study showed was there's a 20% reduction in overall mortality for the patients who underwent CT screening. And that's a better survival mortality reduction than mammography, colonoscopy, and PSA all combined.
Oh, wow.
2011 in New England Journal of Medicine. CMS did not approve that to 2015, and the other medical insurance companies have come on board with that. Now, actually, and that would only pick up about 12% of the lung cancers in the U.S. More recently, the U.S. Task Force on Healthcare came out in, I think, September or so in the fall, of increasing the patients we can screen. So it's now between 50 and 77.
Okay.
Well, actually 80 for their guidelines in 20 pack years.
Okay.
So we're seeing more smokers for that. And the way it's done, it was very unique at Georgia Cancer Center. Our former colleague here, Eric Schroeder, was a thoracic surgeon. And Augusta started the one of only 2 free lung cancer screening programs in the country.
Oh, wow.
And that was from 2014 to 2021. They screened about 3,400 patients. The other one was at the Leahy Clinic.
Okay.
And so we offer that free. Now we have to charge, but we can't undermine CMS
Okay.
for it. Back then we were doing about 35 scans a month. Now we're doing about 50.
Okay.
And still we're increasing that number and so forth.
Okay.
The problem of living in the South, we have nodules in our lungs inherently because we live here. The reason that is one is from the soil, fungus infection called histoplasmosis. Also another condition called sarcoidosis. So we can't have nodules in our lungs that are benign. So we can't take all those nodules out. So we worked on different ways through that. So we have these certain algorithms that we go through and so forth. Also, too, in about 30% of the patients, we find significant findings. They're called S findings. Coronary artery disease, breast cancer, gallbladder disease, renal tumor. So we catch other things, too. So you can't just, forget about those things. Also, too, this is just not one scan. This is until the age of 80.
Okay.
It's a continuum. So these patients will continue to grow with you.
Is it every year?
Every year.
Okay.
Yeah, every year. And so it's an annual scan. Patients get very nervous about that and so forth. And also, too, within our area, if you look at the national numbers in Atlanta Metro and D.C. and so forth, the minority population is about 7 to 10%. We run around 32 to 34% minorities, which is great. Better access for care and also to find their cancer at an earlier stage. Dr. Ratwan was looking too much.
Yeah, no, right.
No, it's fine.
It's all very important information. But I think that kind of dives into the point that, minorities, like you mentioned, they have a more virulent disease. And you see that those patients get detected at an advanced stage. And thanks to the screening program, then, one of the advantages of that would be that you're detecting cancer at an earlier stage. Yeah. And you're curing more people rather than just treating them, which is what advanced cancer would entail. Okay. And so to that end, I think that is a huge asset that we are able to do the screening programs and then pick up these cancers at a much earlier stage. And then, there are newer developments like we were mentioning earlier, and surgery being the only curative option right now, surgery and some radiation with chemotherapy at times. But even there, we have room to augment it. And thankfully, we are doing we have studies that now have shown that we are able to reduce the size and in some cases eliminate the cancer with chemotherapy before operating on them. And at the very least, it improves the operative technicalities, like decreases the time on the table and the time the patient has to stay in the hospital and such. And at no cost to the patient in the sense that you're giving chemotherapy prior to it. So it decreases the risk of this cancer spreading anywhere, shrinks it down, makes it easier for the surgeon to offer a cure. And so we are offering that treatment at this time. And so we work together and we try and get these patients enrolled in these newer drug regimen treatments where they get that drug first and then they go on to get surgery. And it's a win all around. And I've seen a lot more of those cases recently that we have treated them in this regimen.
Well, and that's true. Because even though if we find a cancer at a small size, those 2 centimeter size, around a nickel, that's not 100% cure rate. Is it because of the biology of the disease, lymph nodes can be involved, or, we follow those patients very closely for the first 2 years and a little bit longer intervals. But we're looking to the future that these people may need some immunotherapy or oral therapy or so forth to make sure it stays away. And number one thing, too, in all this is smoking cessation. So when the patients come in for screening, if they're still smoking, we refer them to our smoking cessation program. We have an outstanding program. Because I will not operate on them if they're still smoking.
Really?
They have to be smoke-free for at least 2 weeks.
Okay.
And a lot of that is just in regards to complications. Because now the majority of the cases we do are performed minimally invasively. That's done thoracoscopy or VATS and VATS or robotic surgery. And that surgery usually have 3 small incisions in between your ribs. And usually it takes around 2 hours to do, usually in the hospital anywhere from 1 to 3 days.
Okay.
Whereas before, we used to have a large thoracotomy, which is a large opening in between your chest. You'd be in the hospital for a week and be sore at 2 or 3 months. Most of the patient after minimally invasive surgery is back doing things within 2 to 3 weeks, even returning to work within a month.
Oh, wow.
So it really changed, and it's less stress on your immune system. There's been a lot of studies showing less stress. They recover better. They have better survival in the long haul and so forth. So it's very important.
Gotcha. If someone were coming to the NOW Clinic, what would that experience look like? What would they expect?
Well, they met by a nurse navigator, and they introduce themselves, and then they tell them who they're going to see, and we review things together in the workroom back there, and then we decide on who's going to see them first, and depending what their stage of disease is and so forth. And so they spend time with whatever physician goes first, and then they go over the scans with them and so forth, take notes and so forth, and then we make a plan. Like if someone needs a biopsy of a lymph node that was positive on PET to determine if the cancer is more advanced and then an earlier stage, then the interventional pulmonologist in 3 or 4 days will do an EBIS, is endobronchial ultrasound, and robotic biopsy. If it's positive on the table, we'll put a port in at the same time for chemotherapy or immunotherapy. And then within a week or 7 to 10 days later, they'll start their treatment. And it's all been done within a 2-week time period, which is great.
Yeah.
And so then they're getting on with their treatment, their lives, and so forth. So that works out very well.
What does it mean to you two and your colleagues? Because you talk about being a tight-knit group. What does it mean to y'all to be able to offer this service and see these patients maybe breathe a sigh of relief because they don't have to come back week after week or every 2 weeks or every 3 weeks?
Well, I think the needs of the patient has to come first. When we call down, well, we can't get a PET scan for a month, that's not acceptable. Even though we're increasing our volume, we have to increase our radiologic, machines and staff and so forth, but that's a good thing. So it's just that we're trying to make that a priority. But, we're a big cancer center. We have other priorities for other malignancies and so forth. So it's all of us working together, but we want to do what's best for that patient. And we don't advertise a lot about it and things. It's word of mouth and things. It's the patient's experiences is that's what you want to really cherish and so forth. And also from family members and so forth.
Yeah, and I think this is, we're meeting these patients at a time when they're very distraught. Because most of the time they're told that there is a mass in the lung. Now, if you just run with that, that can be nerve-wracking to somebody who doesn't know what the next step is going to be. And so when the patients come to us, they're in a very vulnerable situation in the sense that, they have been very anxious about this disease that they need to get addressed. And we are not only able to tell them what the next step is, we are able to tell them what the next 4 steps are and actually implement those in one sitting to where they then directly go on to treatment. And I think the service that we provide to the patients there, because obviously we want to cure as many patients as we can, but at the very least we want to give them comfort. And I think this goes a long way in doing that.
Comfort and hope.
Absolutely.
Because a lot of times they're on the internet and they've looked at different situations,
Yes,
which isn't their situation.
Yeah.
And that's the worst. So you got to back them down, off of that, and that's very important. Also, too, there was a landmark article that came out almost a month ago, study that I was involved in, and look at when these cancers are found to be very small, less than 2 centimeters in size. The old adage was that they always had to have a lobectomy. The entire lobe of their lung had to be removed. Well, this study showed that you can, instead of having a lobectomy, you can have a segmentectomy. Okay. That's a smaller piece of the lung and an anatomical resection. Same survival. So that meant the patient had less complications. Also, more lung was preserved. It was often similar to the literature for it used to be everybody would get a modified radical mastectomy and a complete lymph node dissection from breast cancer. Well, it changed after this lumpectomy and radiation. Same thing for us. And so it was great. And so some of these patients will bring those articles in, or their family members a lot.
Yeah.
It's like this, the patient's daughter brought this paper in. I want my mom to have a segmentectomy. And I said, well, I believe in that study 100%.
You were involved in it.
Yeah, because I was one of the authors of it. I got you. See, I was like name number 12 down there.
Okay. You're still on the list.
Yeah, still on the list. But I'm glad that they're involved in their patients' care. And so that's very important to do that.
Talk about we were going to get there, but talk about the individualization of a lung cancer treatment plan, because we've talked about this with other types of cancer that we've done episodes and interviews with, but it really is so different nowadays with the type of treatment plan that people can have.
Well, and the big thing, and this goes more to, oncologic treatment, systemic treatment, these treatments for every person is individualized. And that's the most important thing. You can't put everybody in the same box. 20 years ago, you did. Because you didn't have the best chemotherapy drugs. We could do the surgery, get rid of all their disease, but there was no good targeted agents afterwards. And the regimens have changed because of tumor markers, different delivery of drugs, not only IV, but orally, and then immunotherapy. So we tailor that to each patient individually. And so that's why, like grandma got this. Well, grandma, things have changed since grandma had treatment. So that's why I think, especially with medical oncology, like Dr. Rabel was saying, it changes like on a daily basis. FDA approves another drug for this, and we've got to stay updated on that. Not only us, but of the care of our patients in the hospital, the pathology department, under tremendous amount of pressure of cranking out all these tumor markers, and this patient should be on an oral drug instead of IV chemo. So all that has changed. So we all work together in this. It's not just the 4 of us in clinic. We have tremendous, 100, 200, 300 people supporting our NOW clinic. So that's what's very important.
Absolutely. I think that the personalized medicine is kind of the holy grail that we are trying to kind of imbibe in our treatments here as well. And to kind of give a little context historically. So for the longest time, we had chemotherapy. And the way I think about chemotherapy, it's like a shotgun. And it's going to kill 10 cancer cells, but for every 10 cancer cells it kills, it will kill 1 normal cell. Mm-hmm. So we'll have a lot of collateral damage and side effects thereof. The field of medicine has advanced to a point now that we are able to do gene sequencing. Each individual has about 22,000 genes. And the test that we send out for sequences every single one of them. So we are looking at whole gene sequencing on each patient with lung cancer. And that gives us a treasure trove of data that is specific to that particular patient and that particular cancer. And that's one aspect where we can now target certain mutations with drugs, which are A, work better than chemotherapy, and B, are much less toxic. So it's kind of a win-win in that regard. And that's just the treatment side of personalized medicine. There's also a pharmacogenomic side where we are looking at certain genetic mutations, and then we're trying to adjust the dose of certain medications and chemotherapy accordingly so that it's tailored to that person and not to kind of a cancer patient. And all of that kind of is something that patients can avail of when they come and see us. That we do gene sequencing, we also should, so that we can A, increase efficacy, and B, decrease the side effects of treatment.
Yeah. And I think the big thing, we'll meet out there like a pre-meet, and then we're going to meet the patient, and we've got this great plan, and they say, well, we don't like that plan. So that's when we have to come in, talk, because the number one thing, we want the patient to have the most benefit, the least amount of risk.
Yeah.
If the treatment is worse than the benefit, then don't go through it.
Yeah.
And then we're meeting these people for the first. And the family, they've been each other, married 50 years or something like that. You know what they've been through and so forth. And with minimally invasive surgery, it's easy to go through. We have different ways where we relieve pain afterwards and so forth. But you've got to get the whole picture. So, and we're not going to, you've got to have this treatment, you've got to have it.
Yeah.
We allow, the patient makes a decision. That's what I always say. You're going to make the final decision to the patient. You're Dr. So-and-so, Dr. Smith. You're going to make that. Not your caregiver, not your daughter, your son, your nephew. You're going to make the decision because you don't want to have to go through it. And I think that's very important. The patient, that's who we care about. They have a voice. We're giving our recommendation. I wish we had a crystal ball on everybody.
Yeah.
To see what was going on, but we don't know that. All we can do is what we know from historic data, new data, and so forth, and we try to, configure that to that patient's condition. I think that's so important, but they've got to help us make that decision too. Because a lot of this is tough treated.
Absolutely. And there are so many nuances to this. And I think it's good that we are able to spend time with the patient in the NOW clinic. Each individual provider is. And by the time they have left the building, they have a very wholesome idea of what their cancer is, what their treatment entails, and how we're going to proceed, and when is the next treatment to get to. And that I think is empowering for a person in that position.
And also, too, I think within the Georgia Cancer Center, we have a group of physicians that are oncology psychiatrists, which has been fantastic because it's a tremendous amount of burden, especially on people who's beaten one cancer, let's say breast cancer, and they're 7, 8 years out, and unfortunately now they've got lung cancer and they never smoked. So talking about missing from a mental standpoint, and so we have a great supporting staff for that, and they work very well with those patients, and even too to help support young children or teenage children when their parents are going through this and so forth. So you've got to have all that, with oncology, psychiatry, you've got to have nutritional support, physical therapy, occupational. In a multi-institutional, multidisciplinary cancer center, you have all that under one roof, which is very important.
What does the future of lung cancer care look like? You've started this NOW clinic. It's been running since October. What does the future of lung cancer care look like? What's the next thing for the Georgia Cancer Center?
So I think the goal is to try and eliminate cancer, or when you find it, to cure it. And so to that end, we are always in search of new trials that we can avail our patients of so that they get the best out of it. And so one such trial is what we have ongoing here at the Cancer Center. Is called the Tumor Infiltrating Leukocyte, or a TIL study. What that entails is that patients that are, like we talked about earlier, that the patient's own immune system sometimes is not able to recognize the cancer. But then there are some parts of that immune system, some cells, which are able to invade and permeate through the cancer. And so the study entails taking out a part of the cancer, enriching those cells that have kind of invaded and are trying to attack that cancer, taking them out of the body, expanding that cohort, and reinfusing those cells back so they can fight cancer in the patient's body. So this is a first-in-state study that we have here at Georgia Cancer Center. And we're really excited with the initial results of that study in earlier phase trials, where they're able to afford very good response rates to lung cancer patients, even after they have been heavily pretreated. So we get patient referrals from around the state in trying to enroll them in that and multiple other studies that we have available, all with the goal of trying to get better, more personalized care to a lung cancer patient, to where, at least initially, this turns into a chronic disease where they live with it and then attempted at a cure, even in patients who have advanced diseases. So that's the future that we are hoping for.
Also, too, I think as we talk in the future, as Dr. Ravel was talking about, we want people to survive and beat the cancer. This was very important to have a survivorship program. Because when these patients get to that 5-year mark for everybody, you can't forget about other cancers they should be screening for. So it's very important. Did you get your mammography? Did you get your colonoscopy, PSA? So you've been fighting the lung cancer for 5 years, but you forget about these other things. So that's why I think it's very important that our survivorship is increasing and growing, and with more staff and so forth, that we can do that so we don't miss other things. So I think, and that makes the patient feel more comfortable. We're not just looking at their lung cancer, we're treating the total patient, the whole patient. So the most important thing is the survivorship program as you get into that.
And what about, I know that we're working on a mobile screening project. What is that going to look like? Can you talk about that?
That's the most exciting. I mean, everything is exciting because we're doing something to help a patient. And the problem with our lung cancer screening program, and if you look at the state of Georgia, only 5% of the patients who are eligible for screening in the state of Georgia get screened today.
5%.
5%.
Okay.
Entire state. Roughly, we have 11 million people
In Georgia. 5%.
5%.
Okay.
All right. In Atlanta Metro, there's roughly 6 million out of 11 counties. All right. There, in the state of Georgia, there's 150 screening sites within the state.
Okay.
And these are affiliated with other medical centers and are freestanding and so forth. 120 of those are within Metro Atlanta.
Okay.
All right. So Metro Atlanta is covered. The other 5 million people of the state, known as the donut, that's the whole rural areas. And that has some of the highest incidence of lung cancer within the state. But there's only 30 sites. So what we're developing and working on state funding right now is that we would have a mobile CT scan unit that could travel about 75 to 100 mile radius out of Augusta. And this will be through the MCG, Augusta University. And that will screen for lung cancer, but also the time they get their CT scan, that would also screen for coronary artery disease. So with that, you're knocking out the two number one killers, in the United States, coronary artery disease and lung cancer. What's exciting about that is that we want to be the first state in the United States to have a statewide program. So MCG has 5 regional campuses or sub-campuses within the state. In Albany, at Phoebe Putnam, is the Southwest. Up in the Northwest is at Dalton and Rome. In the Northeast is Athens. Okay. Augusta's here in the center. And then in the Southeast is Savannah and Brunswick. Okay. So if we can focus 5 mobile units out of those areas, you will tackle a large number of patients who do not have screening. And because they can't get there because of financial. They can't get there because they can't get off of work. Whereas who wants to drive 100 miles when you get a 15-minute test? Yeah. So forth. So by doing this is what we're working on now. And so this would be a major game changer, because right now in the state of Georgia, for healthcare outcomes, we're 51st. We're last.
Oh, wow. I did not know that.
Last.
I did not know that.
A lot of that is because of access.
Okay.
And so we've got it. Atlanta Metro's got things covered.
Yeah.
We've got to do a better job throughout the state.
Yeah.
So that's what we're finding through the state government. Also, we're looking at our federal partners with our senators right now and so forth. So because first of all, this will be the first mobile unit within the state. Okay. We want to have it based to the Medical College of Georgia, since we're like the 8th or 9th largest in the country now. Yeah. They would be based in these regions, and so we would help with other health systems, private, non-for-profit, but we're the only public university that's looking at doing that. Yeah. So that's very exciting. So we would be bringing people back here for treatment and so forth.
So partnerships in the NOW Clinic, partnerships at the state level, partnerships at the federal level, partnerships with other hospitals. It really is all about building those relationships.
It is, and that's perfect. So it's a cancer partnership is what you're trying to achieve with that. And because not one person can do it. Dr. Ravel can't do it. I can't. You've got to have a tremendous team. And as you know, the weakest team is hard. And in a team, it's not, there's no I in team. Yeah. There's me, but there's nothing like that. But the big thing is we have to work as a team. Yeah. And you have to educate people about it and so forth. Also, even at the time of surgery, there's always this old thing, well, if you open them up, the air will get in, their cancer will spread. I hear that all the time. That was old wise tale.
Yeah.
Because back then they didn't have PET scans. They didn't have scans to really know how much disease they had.
Yeah.
A lot of times you couldn't tell. You do it in incisions that have cancer everywhere. Well, you didn't know it because you didn't have the right diagnostic stuff.
Yeah.
So it's just changing that mindset that we can do something for you.
Yeah.
And so if we want to be there, we want you to be our biggest patient advocates to go out and bring more people in.
Well, gentlemen, I appreciate your time today. I have learned quite a bit, and I hope those watching or listening to this podcast have learned a lot as well. Thank you very much for your time. I appreciate you both being here.
Great. Thank you. There'll be a test after this.
Okay, I'm ready. I've got my notes. Well, if you want to follow, rate, review, please do A Cancer Conversation. Just search Georgia Cancer Center on Google's podcast, Apple's podcast, Spotify. You can search, you can follow, you can rate, you can review. Please let us know how we're doing. If there's a topic you want to hear about, let us know that as well, because we want to be a resource for those out there in the community. So thank you. Have a wonderful day, and we'll see you next time.